Thank you for taking time from your busy day to watch this special presentation from the El Paso County Medical Society. I'm Dr. Joel Hendricks, President of the El Paso County Medical Society, and it is my hope that you will find our program of great interest, educational, and informative about the medical care provided by some of our best physicians in our country, right here in the borderland. From all of us at the El Paso County Medical Society, please enjoy tonight's program.
According to the CDC's National Health and Nutrition Examination Survey, about 70% of adults in the United States are overweight. 32% are obese, and we'll talk about the definition of overweight and obese in a little bit. Women have unique issues with weight, post-pregnancy weight, menopause weight, and what roles do the hormones play? Our program addresses concerns about obesity and medical consequences. We'll also talk about options that are available to help lose weight that is necessary to be healthy. Everything from traditional exercise and nutrition, but also weight loss surgery. If you have questions regarding this or any other topic that's covered here on the El Paso Physician, please email the El Paso County Medical Society, and that email address is epmedsoc@aol.com. Again, epmedsoc@aol.com, and we will have them answered by one of the doctors that appear here on the program. This evening's program is underwritten by Hospitals of Providence, and we also want to thank the El Paso County Medical Society for bringing the show to you for over 26 years now. I'm Catherine Berg, and you are tuned into the El Paso Physician. Welcome back. We are talking about women's health and weight loss surgery. Why is it that we're talking about weight loss surgery and specifically with women tonight? I have found through our doctors that over 70%, actually over 80% of those that are seeking weight loss surgery are women. And of that 80%, they are women of childbearing age. So that's a big deal. And we don't talk about it often enough, and sometimes separating the sexes out. So we're going to talk a lot about that. So with us this evening, we have Dr. Rebecca Montes, who is an OBGYN, and you're going to give us some very specifics on the gals. And again, since we're talking about weight loss surgery, mainly occurring with women who are still of childbearing age, there's a lot that goes into that. And hormones, I think, is a little bit.
Yes.
Pregnancy is a little bit. And so we're going to really dive into that. And again, if there's questions about this, always email the El Paso County Medical Society, and we'll make sure to get those questions answered. We also have Dr. Benjamin Clapp, who is a bariatric surgeon and who's been with us several times in the past. And I have to acknowledge the obvious, because now I'm looking at you and I just have to crack up, because I have all of these graphics, which you're going to see in a little while as we put things together. And there is just a portion of your paper that I transferred over here, and I tore it up in front of him. He's like, "You're tearing up my paper." I'm not tearing up your paper. I already transferred. But this is just to kind of keep me on track. But Dr. Clapp, welcome back.
Thanks for having me back.
I want to kind of start off with the idea of being healthy. And yes, it's the idea of weight that we're talking about tonight. But in general, weight carries so many different issues that affect people. And when I say that, I like to just kind of start off on everybody thinks about BMI and what the definition of BMI is. So Dr. Clapp, if you can kind of describe what that is. And you were talking earlier prior to the show also that with BMI, there was in the past a certain BMI number that we thought, okay, well, after this number hits, now it's time for surgery. But that's also been adjusted over the years, right? So let's dive into that.
So the BMI stands for body mass index. And what a body mass index is it tells us a little bit about the patient's characteristics of their body. So it's not a perfect metric by any means. It was created in the 1880s by a French statistician. We can argue about its usefulness, but the thing about it is that any doctor, nurse practitioner, or PA or medical assistant can calculate it from your height and your weight. And so what we do is we look at the height and we look at the weight and we divide that by height squared. So it would be, kilograms over meter squared, and so it's not a perfect way of measuring things. But a bodybuilder may have a BMI that would be considered obese, but it's just because of their muscle mass. But for most people, it works very well in populations.
Okay.
So in the past, we would use the body mass index of a cutoff of 35 to have somebody qualify for surgery, and they would have to have two associated comorbidities or things that are related to.
So talk about what a comorbidity.
That would be something
is,
like diabetes
Okay.
or high blood pressure or obstructive sleep apnea or urinary stress incontinence, arthritis, anything that we can relate to obesity.
Okay.
Obesity helps contribute to that. Or if they had a body mass index of greater than 40 and they would qualify. And most insurance companies do pay for bariatric surgery now within those guidelines.
Okay.
However, for the first time in 31 years, the American Society of Metabolic and Bariatric Surgeons and the International Federation for Society of Obesity got together, and we've revisited this, because for 31 years it was static and it stayed there. And we realized that even as low as a BMI of 30, people will benefit from it. Because if you have prediabetes and high blood pressure and you're developing sleep apnea and you have a BMI of 32, why would we wait until you have a BMI of 35?
Right.
In real terms, that could be the difference of 15 pounds. So we've dropped that to 30. So now it's 30 with 2 associated comorbidities or greater than 35.
Okay.
Now, insurance companies haven't quite
Yes,
caught
that's
up to
always
that.
the big question. So I'm super happy that you brought that up. So again, when you're thinking about our audience and there's surgery, there's a point where people see bariatric surgery as elective surgery, and there's a point where bariatric surgery really is a health issue surgery. So I'd like to, again, for the perception of what people hear and see out there, what do you guys hear and see about that? And maybe specifically on this, and then what I want to do is come to women's issues on that as well. Because again, it's the perception. You all are doctors and you get how, and you said that beautifully earlier, why do we wait to a certain point? Why do we wait until they're sick to fix something?
Right. And so one of my pet peeves as a bariatric surgeon, every bariatric surgeon has the same pet peeve, is that people that think this is some sort of a cosmetic procedure or something that's
exactly
necessary
my point.
for their
Right.
health. And there
Right.
couldn't be anything further from the truth. Yes, this is an elective operation. There's never a time when this is an emergency, but it's a life-saving operation. It's not cosmetic. And when we look at the root cause of all these medical problems, it's obesity. And in fact, we classify obesity as a disease. We don't even think of it as a condition. It's a disease. And so does the Centers for Medicaid and Medicare. They think of it as a disease. And when we look at the combination of obesity and diabetes specifically, I mean, you're looking at taking a year off of someone's life. For every point that they're over a body mass index of 35, they lose a year of life. So it's a public health nightmare. It's a public health crisis in this country and across the world. And we need to get rid of the idea that this is some sort of elective cosmetic procedure. Nothing could be further from the truth.
Right. And there's all kinds of, and I know, you're looking at any kind of a platform of watching TV. It's like, why do we in America, and this was a point that you made too, America used to be in the top 5 of people in the world that were obese, and now we're dropping a little bit. Yeah, I know. But I feel like shows like this and education and people kind of getting on the bandwagon of what's happening, that's helping out a lot. I would love to talk, Dr. Montes, because in this realm, we've not had an OBGYN and specifically speaking about women issues when it comes to bariatric surgery or weight in general. I mean, we all talk about it. I'm 56 years old. Menopause hit. I'm a little meatier than I've ever been in my entire life. Yes. But what does that mean, and what does that translate into, and what is the OB's role when we're looking at just seeing your patients every year for their yearly exam? Where does that conversation come in?
Well, that conversation comes in quite often.
Okay.
Women in general are always obsessed with their weight.
Right.
Constantly. They're, and a lot of women are overweight or obese. And one of the things that they're always, they're obese not because they want to, and they try by so many means to try to lose the weight. And so they're always constantly looking at us for guidance or for help.
Right.
So one of the things that I have to do as a physician, every time they come in for their annual exam, their well-woman exam, I have to check their BMI, see what it is, and then to kind of provide some sort of guidance and give them some sort of resources so that they could go ahead and utilize to be able to achieve the weight goal that they want. And at different stages that we are as women, in adolescence, when you're in the reproductive age, and then when you transition to menopause, you go through a lot of different hormonal changes that are going to affect your weight. And so, we have to address those issues at those different, times of their lives for that.
So when you're talking about hormonal changes too, and I'm thinking of myself and my daughter and just in general. So before you hit puberty, and then puberty hits, and yes, you start developing breasts, you start getting the hips, and things start filling out a little bit. And then once you hit your 20s and you really looking at pregnancy weight, I guess the fear is too that there is the thought of being too thin and the thought of being too thick. And where in general is that line when you're looking at people in their 20s? When I say people, women in their 20s, because there's so much media around it. There's so much, not just about being healthy, but about just being skinny. But that's something too we want to look at too. It's not just about being skinny, which is a whole nother word that is loaded, and I respect that completely, because overweight is a word, obese is a word, morbidly obese is a word. Where on that BMI chart do you ask women to fall?
Well, we always want them to be at a normal BMI, which is a BMI anywhere from 18 to 24.
Okay.
Something less than 24.
That's the question, between 18 and 24.
That's
Okay.
where you really want women to be at a normal BMI, but women get so obsessed with their weight. And then we also have to look at the opposite side of that, with eating disorders as well, because they're too obsessed with weight loss. But I usually address the issue when their BMI is greater than 25.
Okay.
Overweight, I'll introduce it. I say, you know what, you're a little overweight. Let's discuss about what type of diet you're doing, exercise, things like that. When their BMI is a little bit more than 30, then I'll refer them to a dietitian. It's important that they get a referral to the dietitian, because a lot of people in general don't know how to eat. They don't know, we overeat too many portions on our meals. I mean, go to Texas Roadhouse. They give you a big, huge steak that's about 12 ounces or 16 ounces.
Dear Lord, yeah, you do. You get 3 or 4 meals in one.
And you really want to eat a very healthy diet. I always recommend the Mediterranean diet. I think that's the best type of diet that anybody should be eating. It's a well-proportioned diet with a well-proportion of your vegetables, your fruits, your fats, your proteins, everything in there with that. And I think that a dietitian will provide a good guideline to those patients as to how they could achieve their weight loss goals in that sense.
Okay.
And then if their BMI is greater than 30 now, and they have comorbidities, or they have a BMI greater than 40, then I'll offer them to refer to see a bariatric surgeon like Dr. Clapp.
Okay. So on that note, for people who are listening to this right now, I don't know if we talked about the BMI calculator, but you can almost put that in any search engine. You can literally put in BMI, body mass index calculator, put in your weight, put in your height, and then take it from there, right? Age is not a thing anymore. Was it at one point?
No.
There's like an extra step, I think, with some other...
No, age.
Yeah, not at all. So from there, and even as because everybody's got their phones with them, right? If they're watching this, they can be like, okay, what's mine? And they kind of pop it in there. So looking at that normal weight. So here's a question now. Somebody realizes, and or a doctor said, you know what, your BMI is 34. Let's say. So we're up there, and they start referring to Dr. Clapp, or like, you might want to consider, what are some of the questions that a patient, and let's say it's a brand new patient, someone who's just exploring the idea of weight loss surgery, what are some of the questions that you find they ask the most, and some of the advice that you give them?
Well, so by the time a patient comes to me, they've really thought about this for a long time. The average patient thinks about this for about 2 years before they approach a surgeon.
Okay.
It's not something that's taken lightly by the patients. It's not something taken lightly by doctors. So they've thought about it. They maybe watched social media, Instagram or TikTok about it. They may have family members that have gone through it. And so by that time, their questions are more the details of how can I get this done?
Right.
If they're coming to see me, they've kind of made up their mind that they're probably going to do this, or they want to do it. I think that it's probably harder for Dr. Montes to interact with these patients because they're on the fence. They're looking for guidance. Should I try another diet? Should I try these new medications that I'm hearing about? Or should I just go straight to surgery, and what's better? And so her job might be even a little bit harder, because by the time they're coming to me, they know they're coming to a specialist.
Right.
Yeah.
Like her conversation with the patient saying, well, look, I noticed that your weight's going up. It can be, patients can get offended.
Oh, yeah.
In my office.
It's a delicate issue.
Right, but in my office, I have all this literature. I have a big sign outside that says I do weight loss surgery, and they know that I'm going to talk to them about it. So it's not. I still do general surgery, and I still get. I think I've offended patients before talking to them about that, but I feel it's my role as a surgeon and my role as a bariatric surgeon to make sure that I'm mentioning this very important thing that could change their life and restore them to health.
Right.
So I don't make any bones about it. I'll just bring it up to anybody. I'll talk to anybody about weight loss surgery, but I think your job might be a little harder.
It is a little bit harder.
Like, are you calling me fat? I mean, well, no.
Yeah, because a lot of times, some women can get offended, and I kind of have to.
Especially because it is very much body image.
But, for the most part, most women tend to be very receptive because they are always concerned about their weight. So I don't really have a hard time discussing it. I think the fear that they have most is the surgery itself. That the complications that might arise from having bariatric surgery, stuff like that. And so I try to give them some guidance on that, because bariatric surgery is a huge commitment. They have to be emotionally prepared and committed to doing that. Because if they have any doubt, then they better not go and get it done. They really have to discuss. But a lot of times I have patients that say, oh, no, I just want to do it on my own. And they've gone years trying to do it on their own. They don't have any results.
Right. And to Dr. Clapp's point, there is where diabetes tends to be a little bit more of an issue, and sleep apnea, which, sleeping seems like, oh, it's a night's sleep. But sleeping is huge if you're not getting it. It really affects your body too. Completely. I have a question as a follow-up of just the mental state, right? When you're looking at being offended, when you're looking at just in general, the psychological effects, and this is good, bad, and indifferent, right? Psychologically, if someone's been overweight for a good portion of their life, it does affect them psychologically. When you're saying about now the mental state of how and when one decides to have the surgery, talk about maybe in your role dealing with women and the psychology around obesity, and maybe talk about the psychology around someone who has seen Dr. Clapp, someone who has had the surgery, someone who is feeling healthy now years later. What have you seen in the weighing of that?
A lot of times when women are obese, they're coming in very depressed. They're depressed because they can't lose the weight. They've tried, and these are women who have tried years and years going through different fat diets or whatever, exercising programs, and they still can't lose the weight. And when I start bringing up the topic of weight loss surgery, and I start planting that little seed that, maybe this is a good thing for you. You might as well consider it. Just go ahead and have a consultation with a bariatric surgeon. Get to know a little bit more about the procedure and see what the outcome is. And the only thing that I tell them that I have from patients who have had bariatric surgery in the past is that I have not had a single patient to date regret their surgery. The only thing that they tell me is, the only thing that I regret from bariatric surgery is not having it done sooner.
Right.
So
I want to bring up one thing, and then I'm going to go into these great graphics of what types of weight loss surgery are available. But Dr. Clapp, you had mentioned earlier about weight loss drugs, or we talked specifically about Ozempic, that was and is marketed and is primarily for diabetes, but it's just the topic of the day. So I feel like if we don't bring it up, we're not addressing the elephant in the room. So let's talk about, in general, the keto diet and all these gummies that you're seeing on the internet right and left, and people are buying them up. And then it's like, well, wait a minute, that was a scam. And how does one know what to try, what not to try, what's real? And then we'll talk about insurance too in a minute. But you know where I'm going with that. Just go to town on that entire topic.
Right. So I'm the medical director of the Bariatric Center West for Providence. And I've been doing this for 17 years. And what I would encourage people to do is think of obesity and overweight as a spectrum.
Okay.
We don't start just with a gastric bypass or a gastric sleeve. Just like if you have diabetes, you probably don't start on insulin right away. We're going to try diet. We're going to try to modify your lifestyle. That doesn't work. We're going to step up to medical therapy. That doesn't work. We're going to add more medical therapy. So it's kind of like that. So when I see patients, they may not all be ready for surgery. And there's a class of, there's a couple of anti-obesity medications, which the newest and best ones are the semaglutide medications, which are Ozempic and Wegovy. And those work great. But we don't necessarily even need to start there. We could start with things like Contrave or Phentermine and some of these old tried and true drugs that can lose about 5% of your body weight.
And what do those drugs physiologically do once they're in their system? Like, what is it designed to do in your system?
Those are usually appetite suppressants. Now,
appetizing suppressants, okay.
When we pull out the big gun, which is going to be semaglutide, which is Ozempic or Wegovy, it's the same medication. It's a GLP-1 receptor agonist. So what we're doing is we're essentially bottling a gastric bypass and injecting it once a week into your body. It's the same hormones that we change when we modify the body when we do surgery. So what we're doing is surgery is we're changing the metabolic set point. So a patient thinks that their body thinks they're supposed to be at 300. We're going to drop that down to 200 through an interaction in the brain and the gut and through gut hormones. So those are our pharmacological targets. So semaglutide works great. You can lose up to 16% of your total body weight. That's pretty good. That's really good. A bypass is about 26. So you're almost getting there in that range. It has to be taken for long term, and it's an injection once a week. About 2 to 10% of people just flat out won't tolerate it.
Oh, wow.
They have pretty bad side effects. And this is spreading like wildfire. It's all over the country now. And we're starting to see as we release this to millions of people that, it's probably going to be around 10% of people that really can't tolerate this medication.
And
now,
so of that 10% of the people that aren't tolerating, so what is it that they do at that point? I mean,
they have to come off of it.
They just have to come off of
right.
it. Okay. And is there another option for them at that point?
Well, at that point, we have then surgery. But surgery can also be divided into sort of procedures. So we have a couple of procedures that we can do that aren't surgery, like an intergastric balloon, and I do that.
Oh,
where
right.
I can put a balloon that fills space inside somebody's stomach. We do it endoscopically. There's no incisions. It's getting a camera in your mouth. We place a balloon. We take it out 6 months later.
So basically, it's tricking the stomach and thinking it's full.
It's full.
Okay.
And it does. I mean, it's exactly what it sounds like. I mean, there's no magic to it. If you drink a milkshake, you're not going to lose weight. It's going to go right past that balloon. There's a procedure called the endoscopic sleeve gastroplasty, which can also be done endoscopically. And there's a gastroenterologist at Providence that does that. And then there's surgery. And surgery's been around for a while.
Describe that one, though, that you're talking about.
So that one is where an endoscope is placed in the patient's mouth. They're under a general anesthesia, so they're asleep completely. And the stomach is sewn, part of the stomach is sewn together, plicated together, sewn together, so that it creates a tubular stomach.
Okay.
Pretty good results at 2 years. We don't have really long-term data on it. We don't have big numbers on it. But there was a recent trial in Lancet, one of the big medical journals.
So this is relatively new. Okay.
Not a bad procedure. It's not
Okay.
covered by insurance, so patients have to pay cash for that. And then, of course, we have surgery, which is sort of our old standby.
Okay.
And across the country, a lot of my colleagues are saying they're seeing a 15 to 20% decrease in volume, and I'm not experiencing that. But these medications are going to do that. I think that there will always be a place for surgery. I think that we're going to see a rebound after these medications. I don't think it's going anywhere.
Okay.
And then that leads to the 4 surgeries that I perform.
So I'm going to address this just because I was trying to do some research on this show before here because I want to go into the surgery with some of these medications. For example, the second set that you're talking about, it works while you're on the medication, but it's not like you can wean yourself off and all the effects stay there.
No, with the GLP-1 receptor agonist, no.
Yeah, so I think that's important to bring up because it's not like if you're on it for life, but if you're on it, you kind of have to continue taking it for the benefits of that.
I mean, if we take blood pressure medication or our blood pressure normalizes, we don't quit taking the medication. We have to keep taking it.
Okay. What I'd like to do now, because I have these great pictures in front of me, right? And then so I'd like to talk about the SADI first, and I'm gonna pronounce it wrong. So the acronym for SADI means what exactly?
The SADI is a single anastomosis duodenal interposition.
Okay.
That's why we call it the SADI. That's quite a mouthful.
And you'll see a graphic of this on your screen that we're going to put up.
This is actually kind of a newer operation. It's a modification of an old operation called the duodenal switch. And the difference is we create a single connection from the ileum to the duodenum, which is the last portion of the small intestine to the first portion, and we divide the duodenum. So we're bypassing most of the intestine. And it also has a sleeve gastrectomy associated with it. So you do both at the same time.
Okay.
It also can be used as a revision for sleeve gastrectomy if a patient gains weight again. So it's kind of, right now we have a coverage decision from Aetna. There are Federal Blue Cross, I think, pays for it. A couple of insurances do. But I think once that gets picked up more widespread, then I think we'll see a lot more of this operation. It's actually more effective than a gastric bypass. It's a better treatment for diabetes than a gastric bypass.
Okay.
Yeah,
and that's a great transition too. And in hindsight, I probably should have asked about this one latest. But the gastric, how often again, percentage-wise, because I know when we talk about the sleeve, that's about 70% of the surgeries that you're doing now. And then gastric bypass is about how many percentage, más o menos?
Well, it would be about the other 25%.
Okay, so this is probably
the SADI
5-ish.
is a lot smaller, but
Okay.
I think it's a growing procedure. I think we're going to see a lot of it. So it's about 2 or 3% of what I do in my practice. The issue is insurance coverage.
Okay.
But it's a great operation. I love it. And I think it's going to be very important for revisions after sleeve gastrectomies.
So here's going to be the question from the audience too that I'm imagining. So when you're looking at insurance coverage, it's almost like FDA approval, right? It's something that has to be done and proven for a certain amount of years. You said this has been going on for about 2-ish years, if that's correct?
Oh, no, it's been around.
Okay, it's been around.
Yeah.
Okay. So is there a reason, and not that you can answer that or have insurances. So insurance covers the most popular at this point, the gastric sleeve.
Right.
more than the others, and why would that be? Is it that it's been around a lot longer? Is it
No,
that it's
actually,
more
the sleeve's only been
proven,
around for about 15 years, but we have a lot of data on it. It's 70% of what we do in the United States. Probably do about 160,000 a year in the United States to 180,000.
wow. Okay.
So we kind of know its outcomes, but we also know that a certain amount of patients are going to regain weight. So I think that's why the SATI becomes more popular now.
I see. So that's a good way of differentiating these surgeries as well. So if you're looking at the sleeve, there's a weight gain. Probably.
It can be about 15 to 20% of people.
Okay. And that usually happens about how many years after the surgery?
It can be anywhere from 2 to 5 years later. I mean,
Okay.
80% of people are going to maintain, but it does have a little more tendency than the gastric bypass and the SATI.
Okay. So let's talk about the sleeve and how that is done, because we're going to pull up that graphic as well. And as we're describing to the audience, what are you doing as a surgeon? Like, what are you doing with the stomach and the sleeve, et cetera? Just explain the procedure if you could.
So the sleeve gastrectomy is a resection of the stomach, and it would look like the sleeve of a suit to whoever first described it. There's nothing in there. There's no foreign body. It should just be called a vertical gastrectomy, but the term sleeve kind of stuck. But we remove about 80% of the volume of the stomach, and it's gone forever. You can't put it back in when we remove it. It's done laparoscopically. It's usually one night in the hospital. It can be done as an outpatient in selected patients. Very safe. So when you mentioned safety earlier, and when you talk about this and look at this, I'm also assistant professor at Texas Tech, and I do a lot of research. And we have a paper under review right now looking at safety of the sleeve gastric bypass versus common operations, hip replacements, hysterectomies, things like that. It's as safe as a gallbladder surgery. So
wow,
we've gotten these very safe as we've directed these operations into centers of excellence and into expert hands. So they become incredibly safe, actually.
Okay.
So about the safety of a gallbladder.
Okay.
So people see that we're not doing anything else to the intestines. It's the least invasive of all the operations we offer, one night in the hospital. So it's patient driven that the volume is patient driven, really.
Okay. And in general, and I know costs are different across the board, depending on all kinds of things, but in general, how much is the surgery of the gastric sleeve? And when you said insurance covers it, do they cover it 100%? Do they cover it 80%? Or
so it's a covered benefit. So it would just be like anything.
Like any surgery.
If you go and get your knee replacement and they tell you, well, you have an 80/20 deductible,
That's
then
great.
you're going to pay
Okay.
20%. It's just like that. Just like anything else.
Has it always been? I feel like that's always been a question that's asked on the program.
No,
as far
pretty
as
much.
what is, okay, very
Same
nice.
thing with the gastric bypass and the
Okay.
SATI when it's covered. There
Perfect
are cash
transition to the
prices.
bypass. Yeah.
Right, there are cash prices, but
Right.
I mean, it is a little cheaper than a bypass.
Okay, that makes sense. So now let's talk about, but again, we kind of giggle about it, but it's truly what people want to know, right? And I take pride in this program and that I try to ask the questions that people want to know. On that note, so you talked about the gastric bypass, and I understand from earlier, when we had done shows in the past, we talked about gastric bypass, and then we also talked about the band, and we're not doing the band at all anymore, as I understand, right?
So there are people doing the band still, but a very, very small percentage of people.
Okay.
We just have better operations now.
Okay.
And, putting a foreign body in like that, it worked for a lot of people. It wasn't a horrible thing. It was when that's what we had, but we have better things now. And so we tend not to do that.
So people, again, who are watching, because we have a lot of people, we've been doing the show for 26 years. And so I say that often because there are a lot of people that come back and go, oh, well, I have the band and I did the band 10 years ago. It's now maybe not working anymore. Is there an option to now go to a different type of surgery?
Sure, you can switch a band to any of these operations, actually. Although I still manage band patients that I put bands in 15 years ago, and I still manage them. I put in hundreds of bands, and I have plenty of patients that are still very happy with their bands.
Okay.
It's just that we don't really put them in that much anymore.
Okay.
But they can be converted to something else.
Gotcha. So let's talk about the surgeon's role in the gastric bypass. So, again, looking at the video here, or the graphic, you can see what's being bypassed here, but what is the idea here? Because there's a lot of the large intestine that's being bypassed,
the small
correct?
intestine.
Small intestine.
But so what we have with the gastric bypass, it's been around since, really about 55 years. So we have a lot of data on this. We have a lot of long-term data on it. We kind of know its ins and outs. It's still considered really the gold standard by most of us, and we compare everything else to it. So what we do is we make a very small pouch at the upper portion of the stomach by dividing it, leaving in a part of the stomach about the size of a golf ball. And then we bypass that portion of the stomach, although it stays in the body. It would still work if we hooked it up later. It would still makes gastric acid, still does things like that. The bypassed limbs of intestines are usually around 3 feet and on both limbs, and then they meet up later. And so food is sort of, going past the stomach, bypassing it, and then all the pancreatic juices and bile and gastric juices kind of
all
come
that happy
later.
stuff in there.
Yeah,
and then, the stuff that makes all the noise in your belly.
That's right.
Yeah. Okay.
But it's got a little better weight loss than the gastric sleeve, better treatment of diabetes, and again, it's kind of stood the test of time. It is more complex, but the mortality of it is the same as a sleeve. Complication rates are slightly higher, and you say something like that, it makes it sound bad when you're actually talking about maybe a 2% to 4% total complication rate, including things like nausea and stuff like that. For serious complications, like a 0.2 to a 0.4% risk. So they're subclinical almost.
Okay.
Risk.
And that's a nice transition too. And Dr. Montes, just because you're next.
Okay.
Let's talk a little bit about post-surgery. So once somebody has a weight loss surgery, and I know there's different nutritional issues that may be coming up and what have you. So just in your practice, and feel free to kind of jump in on this, but what is it nutritionally that may or may not be different once somebody does have a weight loss surgery, and how does one manage weight loss surgery going forward? And again, basically through nutrition. I don't know how to say it, how to describe it going forward.
Well, first of all, as a gynecologist, women who undergo gastric bypass or gastric surgery, they usually don't have regular periods. And so one of the things that we noticed immediately after having gastric bypass is that they're going to lose a lot of significant weight, and their hormones are going to kind of revert back to normal, and they're going to start having a lot of menstrual cycles.
Okay.
So one thing that I do want to point out.
A lot is an abnormally more than once a month?
No, they will start
so
having.
They'll be having
let me rephrase. They'll start go back to normal. So now they're going to start menstruating normally.
Okay.
And one thing that I do want to mention, ACOG, which is the American College of OBGYNs, they recommend if you don't want to get pregnant during this time, because as gynecologists, we don't recommend for them to get pregnant right away. We usually want them to wait somewhere about, I think bariatric surgeons say maybe 12 to 18 months. We prefer 18 to 24 months.
Okay.
And the only reason why we want them to do that is because they've invested so much in trying to get this weight loss surgery that we really want them to optimize their weight loss goal. And also at this time, we also want to make sure that we're looking out for any type of micronutrient deficiencies or any type of complications that may or may not arise after having weight loss surgery.
Okay.
So if we prefer them to be on some sort of birth control. The only thing that we don't recommend is an oral birth control, because sometimes they might not be able to absorb that medication orally due to some micronutrient deficiencies. And so the birth control pill might not be as effective.
Okay.
So we do provide other forms of contraceptives that are better effective than a pill.
Okay. And so absorption is kind of where I was going to originally as far as nutrition goes. When we're looking at, and again, we're looking at prenatal medications, et cetera, when someone does want to get pregnant. So what I think stood out to me so well is when people are obese at a point where it does affect hormonally your system, that you're not menstruating in a normal scale. And that's something that I didn't think about until you brought that up. So on that note, with BMI, for example, when is it that the overweight becomes such an issue that you're not menstruating normally?
Usually, and it's different for every woman, but usually if women can have a weight loss of about 10%, that is enough to affect their menstrual cycles. And they can actually start having normal menstrual cycles after that. So it really is kind of tailored to the individual.
Okay.
But when they have weight loss surgery, we do see that their menstrual cycles can return back to normal as soon as 3 months post-op.
Okay.
Sometimes even 4 weeks after that.
Okay. And I'm understanding too, if I could, because I have here a specific question that I have from previous shows, can people get pregnant after having weight loss surgery?
Absolutely.
And so what I'm understanding from you a little bit is that sometimes it is optimal to have weight loss surgery so that you can then carry the pregnancy and carry everything healthy-wise.
Yes, because I would much rather have somebody have bariatric surgery, get to their optimal weight goal, and then become pregnant, as opposed to having a patient who's obese and pregnant.
Okay.
Because obesity in itself carries a lot of complications and morbidities.
Talk specifically about that, because I think that's something we don't hear often. So there's diabetes, gestational diabetes that I understand too. So if you are obese and pregnant, and talk just in general about some of the complications that happen with those two combined.
Right. Being obese puts a patient at risk when they become pregnant of having a miscarriage. They could have a stillbirth. They could have congenital anomalies. They get themselves at risk of having gestational diabetes, hypertension, preeclampsia, HELLP syndrome. All of these are complications with obesity. In addition to that, they could have a large for gestational baby, which can put them at risk for having a shoulder dystocia where the baby can get stuck at the time of vaginal delivery.
Oh, gosh, yeah.
Or it also increases the risk of having a C-section. And if they have a C-section and they're obese, sometimes they could have poor wound healing, and they could have a wound infection or wound dehiscence. They could also have an increased risk of having a thrombus. They could have a DVT on their leg. They could have a pulmonary embolism. So all of these are complications that can arise from being pregnant and obese.
Okay. And once you take the obesity, and this is something I didn't talk about earlier, so I kind of hinted at it, but there's overweight, there's obese, there's morbidly obese. And when we're looking at those different stages, and I know that Dr. Clapp, you were talking about by the time somebody has an opportunity to see you, this is something they've discussed. This is something that has been, that's been going on. We spilled water. I'm going to acknowledge the obvious here. I don't have, you know what? I have a scarf. Check
don't
this
use
out.
your scarf.
Ta-da! So by the time somebody gets to you, and let's say that now morbid obesity is in the picture. It's not just that there's obesity and now I'm morbidly obese. When it's hard for me to say this because height and weight is a thing, but how much does one have to weigh for them to be morbidly obese? I know it's with the BMI body chart.
So really, it's a BMI of 35. But
okay. That's morbidly obese.
Right.
Okay.
We actually prefer the classification of class 1, 2, or 3 obesity.
Okay.
Morbidly obese kind of
it's
has
a terrible word.
Yeah.
Can you tell I'm having a hard time getting it out of my...
So I didn't want to get all, corrected.
Yeah, it's an awful wording,
I didn't want to correct your hate speech, but no, I'm just joking.
I know. But literally, I was looking at this and I thought, okay, well, what are the different stages? And that's how they have it
well, it's really
with
interesting.
BMI calculators.
So we collect numbers on everything, right?
Yeah.
The government does, we do, insurance companies do, everybody does. And when you look at, for example, a BMI over 35, for every BMI point over 35, you increase your risk of preeclampsia by 3% for everyone.
Oh, wow.
So it's just,
okay.
it's not a healthy thing to be. Plus the issues of fertility. I mean,
Right.
and PCOS and things like that. And when we get people to lose weight with something like a sleeve or a bypass or by other means, their fertility increases by 80%. Their ability to carry a healthy pregnancy
and tell
increases.
us why. So again, explain to the audience why are you more fertile when you're not obese? Physiologically explain why that's the case.
Well, I'll take a shot at it, but she knows a lot more about it. But fat's not an inactive substance. It's a very hormonally active substance. And what that does in your body is
that is a hormonally active substance.
Oh, yeah.
That right there.
And when you have these sex hormones, like estrogen in a female, progesterone, or testosterone in a man, when a person has a lot of fat cells, it will drive their sexual hormones towards an androgynous state.
Okay.
Where it's a precursor to being male or female, but it's neither. And you're going to have trouble with your cycle.
Right.
That's her whole job.
And if you start having more of androgen-like hormones, then you're not going to have normal cycles anymore. You become anovulatory. You're not going to be ovulating more because that's going to affect your ability to have a normal menstrual cycle.
Yeah.
And then that's where the infertility comes up.
Sure.
Right,
and even
okay.
with men, 80% of my patients are female, but even with men, they're going to have disorders of sperm motility. They're going to have a lower sperm count. They're going to have lower testosterone. It affects everything. It affects everything in your life.
Okay. And it does affect everything in your life. We're kind of at the point where we've got about, 18 minutes before the show ends. And the reason I'm saying this, I've got a ton of questions here that I can talk about, but I want to focus on some things that you wanted to talk about before you got here. Because again, to me, this is new for us when we're talking about weight loss surgery, of very much bringing in the female group in. So in general, as an OBGYN and talking about this, what are some of the questions that you get asked? I know you bring, when people come in to see you, there are certain things that you ask them, but in general, what are the questions that you get asked from women in general about their health with weight and going down this road? And I know there's so many, right?
Yeah.
And again, you were talking about too, you don't want to offend anyone, because once they get to Dr. Clapp, to your point, they're already kind of in the mindset of, I need to have some kind of surgery. So we can talk about, and let's talk about the age group. I think when Dr. Clapp was showing me about people who are in this, it's women from 35 to 45 is the
25 to
biggest group.
45. Yeah.
Okay,
Reproductive
25
age
and
women.
45. So this is like, again, childbearing years,
And
body
most,
image is so huge, etc.
yeah, and like I said, most of these women that are getting bariatric surgery are in a reproductive age, and most of them want to have a pregnancy. Most of them want to
Okay,
have
so
pregnancy.
that is primarily what they're asking you. They're looking at trying to get pregnant and this issue going forward. Okay.
That's very common for me. I mean, they come in and say, when can I have a baby? I heard this will help me have a baby. And yeah, so it's exactly. And so I guess my question to you would be, like, how do you guide them when they're like, they've had bariatric surgery and they're planning a pregnancy? What would you say?
Well, again, we recommend for them not to become pregnant, within the first 18 to 24 months, but that's recommendation. That's not reality.
Right.
The majority of the patients, they start losing their weight, they start feeling really good, they start, they're not using any protection.
Right.
Or they're taking a birth control pill and it might be not working as effective as it should be. And what do you know? They're pregnant. So now they're coming to me and because they haven't achieved their weight loss goal, they might still be obese, and pregnant. And so they're still going to have that risk of having gestational diabetes, of having hypertension, preeclampsia. So we need to monitor for micronutrient deficiencies. So I have to check to see whether or not they're having adequate intakes of
So repeat
vitamin.
that, micronutrient deficiencies.
Yeah. So most of
Okay.
the time when you have weight loss surgery, you may become deficient in the fat soluble vitamins like A, D, E, and K.
A, D,
E and
and
K.
K. E and K, vitamin E and K. Okay.
You can also have iron deficiency. You could
Right.
have folate deficiency. You could have thiamine deficiency. So we need to make sure that we monitor to see whether or not they're deficient in any of those, and we'll check them every trimester
And
during
these
the
are
pregnancy.
deficiencies that in general kind of go hand in hand. Again, I was talking about nutritionally, what you're able to absorb in the body after some of these surgeries
Right.
versus
and
if you didn't have the
sometimes if they're
surgery.
not absorbing them orally, then we might have to replenish them IV, and we might have to give them IV infusions.
Okay.
Once a week if they become severe anemic. Okay.
Okay.
The
And
other
this is during pregnancy?
Yes.
Okay.
And we do encourage the patients to continue taking their vitamins that their bariatric surgeon has prescribed. The only thing that I would make different is that I think that the vitamins that you usually prescribe have a high amounts of vitamin E, and those could be teratogenic on a fetus. So it could cause birth birth defects.
Okay.
So we usually recommend vitamin E levels that are less than 5,000 international units.
Okay.
So to switch them to a prenatal vitamin that will do that.
Yeah.
That would be the thing with it.
That's exactly. If they got, I think they should plan it, and if they don't plan it, we still need to get them on those vitamins right away.
Yeah.
The other thing that we have to worry about is women can get morning sickness, and then that can affect it even more. So it becomes a vicious
course,
cycle
right.
of not being able to get their vitamins because they're vomiting, and then getting more vitamin deficiencies. And so that's when something like IVs would be very helpful. So we got to watch them very closely. Now, statistically, they're going to carry their pregnancy a little easier.
Yeah.
Things will be better, but we've got to watch them real closely, and the patient needs to take responsibility too with their OB and hopefully their surgeon. They can come and say hi to me every once in a while. But
Right.
we all got to work together to make sure that it's the safest thing possible. But it is very safe after surgery.
Yeah, it is. And I prefer them, I would much rather them get pregnant immediately afterwards than for them to be still obese
Right.
and then be pregnant with that.
Exactly.
And another thing that I also want to say, also depending on the type of procedure that they had, if it's a malabsorptive procedure like the Roux-en-Y or something like that, they might not be able to tolerate the 50-gram glucose tolerance test when we give it to them, which we usually do at 24 and 28 weeks.
Let's bring that up. So say that
Okay.
again.
That's
So 50% glucose tolerance test. Tell me what that is.
It's this very high sugary syrup basically that they drink within a 5-minute span. And what we're doing is we're trying to see if they're at risk for gestational diabetes during the pregnancy.
Okay. And this is done before they get pregnant because we're looking at...
No, this
No?
is done when they're pregnant. So
Okay.
we usually do it if they have a family history or they have a history of gestational diabetes in the prior. We'll usually do the glucose load immediately when they come in at their first initial visit. And then we'll repeat it again between 24 and 28 weeks. Because usually around that time, they'll start to develop gestational diabetes
Okay.
if they're prone to having it.
Okay.
But if they have certain procedures that with the gastric bypass, they might not be able to tolerate a glucose load, and they could have at risk of having dumping syndrome.
That's another one that I have from shows past, dumping syndrome. So I want to first talk about the explanation of what gestational diabetes is and why is that dangerous when you're pregnant. Is that something also that later on in life, after pregnancy, years later, can come back? So gestational diabetes, why is that so bad when somebody is pregnant? And let's talk about that, because we hear it often enough where it's like, oh, I had that. Oh, my sister had that. Or my cousin had that. But it's not really explained why it's such an issue.
When you're pregnant, the placenta tends to produce a lot of hormone, insulin-like receptors, hormones that can mimic the state of pregnancy. And your pancreas usually produces enough insulin to be able to decrease that amount of glucose load. But in women who can't perform that, then they end up developing gestational diabetes. Now, if you have gestational diabetes when you're pregnant, you have a 50% chance of continuing to have gestational diabetes. Well, not gestational, just becoming a diabetic after you've had your baby. Mm-hmm. So usually, if I have a patient who has gestational diabetes, we usually do a 75-gram glucose load 6 weeks postpartum to assess whether or not they still have diabetes. Excellent. Or they're going to become diabetic.
Okay. And is there harm to the baby with having gestational diabetes?
Yes. If your diabetes is not controlled, then the baby can become large for gestational age. Okay. You can have a macrosomic baby.
Tell me what that is.
So it's a baby that's basically larger than what the gestational age is.
Okay.
And the baby is not diabetic, but the baby's pancreas will be producing a lot of insulin to try to regulate the amount of glucose that's circulating in mom. So there's a risk when the baby's born that the baby can become hypoglycemic and the sugars drop significantly. And that can affect the baby.
So that is very, very specific. So it's hard to say, gestational diabetes does affect, again, we hear about it often about, well, later on in life, then the pregnant person does have a higher risk of developing diabetes. But we don't hear often about what's happening with the child inside. So, and that's why I want that to really be something that we talk about.
Not only that, but if you have a diabetic patient who's pregnant and they're not controlling their sugars, there's also, especially in the beginning of the pregnancy, there's a huge risk of stillbirth and congenital anomalies, so birth defects with the pregnancy as well. And, we want women, when we're following them for their diabetes, we want them to be honest with their sugars, because a lot of times they're not. Right. And it's going to show up. It will show up eventually, because we'll see it when we monitor the baby will grow, or we'll be able to find out whether or not they're truly compliant with their diet and their diabetes.
Yes, Dr. Clapp?
Well, it's just interesting. Obesity is just such an interesting disease. I mean, people come to me all the time and they ask about this, like, I'm worried about the complications of surgery. I'm worried about this. And as a surgeon, I'm a risk manager. I manage risk because what we do is inherently risky. And how do I make sure a patient walks out of the hospital under their own power, whatever surgery I do? And when you hear these complications, like that convey all the way into the offspring, into the child.
Right. And that was my point of really trying to hammer in on that.
And if we can reduce those risks, we really need to consider that, and we need to flip that question on its head. Like, oh, how risky is the surgery? Like, how risky is not getting the surgery? How risky is trying to carry a child or a baby for 9 months, with gestational diabetes, with preeclampsia, with HELLP syndrome, which are life-threatening conditions.
So for people who don't know preeclampsia, explain what that is too, and why obesity.
I learned about it in medical school, but she's the expert.
Okay. So
preeclampsia basically is hypertension while you're pregnant.
Okay.
We usually see it in the third trimester. Sometimes,
so later on in the pregnancy.
So we always have to monitor for any protein in their urine and their elevated blood pressures. Because if you don't control the blood pressures, then the patient can have a stroke or a seizure. And, that's not enough oxygen getting into the baby. So the baby could have placental insufficiency, and the baby may not thrive and could have growth restriction as well.
Okay. And I have heard too that's, not often, but babies are sometimes taken early because of the dangers of going to full term, or the preeclampsia is just an issue big enough for the babies to to be taken early. It's a terrible way of saying it.
Yes.
But going into to labor earlier and having that done. I have so many questions here that talk about El Paso specifically and the nation in general as far as diabetes. So we're talking about gestational diabetes, but in El Paso, we have a higher rate of diabetes anyway. Is that also the case with pregnancy in women that have gestational diabetes? Is that higher in El Paso than it is in other cities that you all are aware of?
I'm not really sure, but I would assume that yes.
Okay. And then here's the other question I always ask when we talk about diabetes, and it's just interesting to get opinions of doctors as to why that is. I mean, why is it our diet? Is it our exercise? Is it Hispanic population? We're 80% Hispanic population. So what is the all
I
the
think
above?
so.
Yeah.
But we're always like in the top, 5% of the cities that have the highest rate of diabetes. And I'm just kind of throwing that out there because often that is associated with weight. This is a weight loss program. We're talking about surgeries. In general, I'm throwing that out to whoever
genetics
wants to
does play a massive role in that. So I'm from El Paso, but I did my surgical training in Arizona. And for example, the Pima Indians have a 100% penetrance of diabetes. Just the
100%.
Yeah, the diet
is that
is
even
just
a thing? I didn't know that.
The diet
okay.
it's a really interesting population study.
Wow.
But their pancreases aren't used to a Western diet. It's just not going to happen. So genetics plays a huge role in it. It does. Our diet plays a huge role in it, and our diet is really what's wrong with everything. It's, when we look at obesity, and we look at our role of diet in obesity, and we look at the role of inflammation in obesity, it's almost like we're dealing with an autoimmune disorder. It's not. It's an inflammatory disorder, but it's almost like an autoimmune disorder, the way it attacks everything. It all, I think, begins and ends with our diet. Now, there's a little more to obesity than our diet. I mean, there's a genetic predisposition, there's family traits, things like that. But the diet plays a huge role.
Okay.
And one of the things that we have to change after surgery, and one of the things that we make people go see a nutritionist for months before we do surgery, is so they get used to those changes in their diet.
Mm-hmm. And so that's a great point too. So I have here some questions about just prep for surgeries. And again, I know we talked about a good 4 surgeries, 3 that are done most often. And when we're looking at surgery prep, so they've come to see you, there is a decision to have one of these surgeries done. At that point, what is the prep period and what do they do? Right. So, we're talking about nutrition, lack of, and we haven't defined dumping yet on this show anyway, afterwards, but the absorption of nutrients in general. So this is an elective operation and we have time to do these, and we want to make sure that people maximize their chances of success. And what it really is a tool, and if we don't teach them how to use this tool and we don't teach them how to effectively use it and use it all the time and get in the habit of using it, then long term they may not have the success they want with it. So everyone that goes through the program has to see a psychologist to look for eating disorders, to look at mood disorders, things like that. Everyone has to see a nutritionist probably multiple times. And then everybody has to go through sort of this educational process where we teach them about these operations so that they can make an informed decision and they know what they're getting. And the insurance companies are the ones that kind of determine how long that preoperative period is, but it's going to range anywhere from 2 to 6 months. Okay.
So even if somebody comes in and pays cash, they're still going to have to do all that because these are very important steps in their journey to getting weight loss surgery and maintaining their weight.
Okay. And when it gets to that point, what could be some things that people decide, well, I'm not going to go through with the surgery? And that's a terrible question to ask on the show because this show is all about the weight loss surgery.
It's fine. There's plenty of people that don't.
Yeah, okay.
That drop out. I mean, they may feel that it's just not right for them yet.
Okay.
They may feel that they can do it on their own. They may feel that just given a little bit more time, maybe these new medications, that they'll be able to do it. And that's okay. I always tell my patients, unless they're 100% committed, that they shouldn't do it. No one can make the decision for them. They have to make it for themselves. It can't be the spouse. It can't be the parents. It can't be it has to be them. It has to come from within them. And then when they're accepting of it, then they'll succeed with it. But if they're kind of fighting it a little bit, then they're going to be very unhappy.
Right.
And we try to prevent that at all cost. Okay. I've had people leave the preoperative area. I've had people say, well, I'm going to go to the bathroom, and they ran away. And that's okay. People are like, well, what happened? Well, we called them, but we're not going to chase them down. They weren't ready for it. And that's okay.
Well, it is a big decision. And that's why, again, I love having the show because I am bringing up the good, the bad, everything. Because sometimes you just have to really dive into it. And when knowledge is power. That's the way I always look at things. Knowledge is power, of knowing how all this works out. When we are, I'm gonna repeat this now because I think sometimes we're about 3 minutes before the show ends. But if there are questions that you have, I know it happens fast. I'm telling you. On that note, I'm gonna say this really quick. And if there's something else we want to add before the show wraps up, let me know. But if you got to the show a little bit late, there are several places that you can watch the show again. Just the simplest is PBS El Paso. So pbselpaso.org. You can go on there and literally on that webpage, you will see the logo of the El Paso Physician. You can find it there. The El Paso County Medical Society website, that's epcms.com. And then everybody I feel like knows YouTube. And so several years ago, PBS put this on YouTube and that works out beautifully. So just go to youtube.com and just search the El Paso Physician. The nice thing about that is that you can go back to literally the weight loss surgery show that we did. I don't even know how many years ago that was, but they're all archived in there. So you can find this show, you can find other shows as well. So I want to throw that out there. And you were just saying something before I said I wanted to get this out. What was that? That's a brain loss right there.
No, that's okay. But they could also go to my website and it has that show on it also.
Let's do that too. Right. Let's go to what's your website?
Oh, it's just Google me. I mean,
just Google you, Dr. Benjamin Clapp. Benjamin
really
L.
love
Clapp.
how you spelled it out and PBS. Look, they're just going to Google it and it will just show
Yeah,
up.
Search engines. That's a thing, right? But sometimes on that note, in fact, this is something great for OBs. Dr. Google is a thing, right? And so sometimes you will get bad information out there. And I address it every now and again. But when people come see you as an OB and they say, hey, I read about, what are some of the things that are misinformed with a lot of people that you see? And how do you direct them to a website and or a search engine that they can get real information and not just stuff that's thrown out there?
Well, I usually redirect them to the ACOG website, which is the American College of OBGYNs for my patients.
Okay, say that slowly.
ACOG.
ACOG, C-O-G.
ACOG.
Okay,
the American
ACOG.
College of OBGYN. That's basically the college that we, as OBGYNs, follow all the recommendations that they have for anything associated with women's health.
Okay, which makes a big difference.
Yeah,
Yes.
you know what? That gave me a great idea. So for us, what I would like to say, especially for my patients, is that go to the ASMBS website, which is the American Society.
Yeah, guys have to say it slower.
American Society of Metabolic and Bariatric Surgeons, and look up the nutritional guidelines. Because my patients that are out there, and there's thousands of them, you got to take your vitamins. You got to take your vitamins. And it's just a good reminder of the official, this is the one that they bless. These are the doses you need, and these are the vitamins you need. So
that's always good to know, because that's always the big question when you're in the grocery store, right?
Dr.
Clapp and Dr. Montes, thank you so much for being here. Again, we've been talking about weight loss surgery in general, but we've been trying to specify women's health and weight loss surgery and who to talk to. And so again, come back, visit the show again, and get all this information. But we appreciate you watching. Thanks for being here and tuning in. I'm Catherine Berg, and this has been the El Paso Physician.
Thank you.